So after that, we see like what is the drug resistance of organisms which we have seen. So which now we have decided like, okay, this is a pulmonary infection, a hospital acquired infection, pulmonary infection in a immunocompetent patient. So here, like, how do I decide like which antibiotic I start? So first, know that initially in the olden days, we used to start with a broad spectrum, and our broad spectrum at that time was restricted still to penicillins. So this penicillins or these beta-lactam antibiotics like cephalosporins or monobactams used to destroy the beta-lactam bond. So this beta-lactam bond of the bacteria in the cellular wall was destroyed, and hence these antibiotics were also competent enough to give a bactericidal effect. But then the bacteria started producing beta-lactamases. So to encounter our beta-lactam antibiotics, beta-lactamases were produced. We started giving BL-BLI combination, that is this beta-lactamase inhibitors. So what are these beta-lactamase inhibitors? We know from the simplest one of clavulanic acid to we have your tazobactam, which we add in the piperacillin antibiotic. Then we have sulbactam, which we add cefoperazone sulbactam. To we have ralibactam, which we add to meropenem, to virobactam, and to finally we have our avibactam, one of the most potent BLI up till now. So these are the BL-BLI combinations we started getting to encounter the beta-lactamases. So bacteria became much more smarter. They started making extended spectrum beta-lactamases. So to encounter these extended spectrum beta-lactamases, we then got carbapenems. So very potent group of drugs, carbapenems like ertapenem, meropenem, ferropenem, biapenem, and all those things. So, imipenem. So once bacteria understood like, okay, they have got a carbapenems, so they started producing another group of enzymes called as carbapenemases. So for this carbapenemases, now we are encountering a problem of multi-drug resistant enzymes, and so we have very few drugs left in our hand to treat these carbapenemases or MDR organisms. We have only polymyxin based therapies or to some extent some tigecycline or newer drugs in the formation of avibactam with aztreonam combinations, which are quite expensive. Now just a little brush up on this classification, that is Ambler's classification of beta-lactamases. So this is a very important classification. You have to remember it at least to have an idea like what kind of enzyme and how do we tackle, and whenever you look at your microbiology reports and the culture sensitivity pattern, it will be very easy for you to deal it. So as per Ambler, these beta-lactamases are two types, serine enzymes and metallic enzymes. The metallic enzymes are mostly in our eastern part of the world, it is zinc enzymes. So these serine enzymes are again divided into A, C and D. The C is the most simplest one, that is AMP-C group of enzymes. These are inducible enzymes. So only when you irritate the bacteria, these enzymes are produced. Otherwise, these are little harmless. The A is nothing but the SHV, KPC, TEM and CTXM, which are mostly ESBLs. That is, mostly they are prone to your carbapenems. They respond definitely to your carbapenems. Then we have another group of enzymes, that is D group of enzymes, which is OXA group, OXA48 and OXA23, which are predominantly produced by the Acinetobacter group of organisms, and these are the multi-drug resistant enzymes. They confer you that multi-drug resistant. Then we have the zinc enzymes, which is NDM, MDL, VIM and IMP. So these enzymes are also quite potent, which require especially aztreonam or a polymyxin based therapy. So these OXA group of enzymes and your NDM, which is New Delhi metallobeta-lactamases, and MBL, which are predominantly found in our ICUs, are very potent enzymes and they confer you that multi-drug resistance.